Hello everybody, we are here in Orlando, Florida for discussion about the highlights on the multiple myeloma from the American Society of Hematology 2015. This discussion takes part of ecancer's educational program. My name is Maria Victoria Mateos and I am a hematologist at the University Hospital of Salamanca in Spain, and joining me are Dr. Dimopoulos from Athens, Greece, Dr. Plesner from Copenhagen, Denmark, and Dr. Lonial from Atlanta in the US. So thank you very much for joining me in this discussion about highlights from us. And I don't know if you agree with me, but if I have to summarize the highlights from this ASH meeting as far as myeloma is concerned, our first transplant is consolidated as a standard of care for young newly diagnosed myeloma patients. And the second important thing that we have learned from this ASH meeting are new combinations, and also the immunotherapy has arrived to the myeloma treatment. Starting by the new combinations, I would like to start with Dr. Dimopoulos about the second generation proteasome inhibitors, specifically carfilzomib. What are the new combinations do you consider exciting in this ASH meeting?
Yes, we have heard the primary presentations of the ASPIRE trial, which compared carfilzomib, lenalidomide and dexamethasone to lenalidomide and dexamethasone about a year ago. And 6 months ago, the Endeavor trial, which compared the carfilzomib, dexamethasone with bortezomib and dexamethasone. And in this meeting, there are several secondary analyses regarding cytogenetics, prior therapies, impact of age for both trials. So it appears that combinations based on carfilzomib may overcome to a certain degree the adverse cytogenetic features which are associated in approximately 20% to 25% of patients with myeloma. KRD may be doing better in that aspect than carfilzomib and dexamethasone. Also, these combinations are well tolerated even in elderly patients, and this is important because we know that myeloma patients are aging. And clearly carfilzomib is replacing bortezomib, at least in the relapse setting, 1 to 3 prior lines of therapy.
Thank you. And Dr. Lonial, what about other exciting combination also based on lenalidomide and dexamethasone, but now in combination with elotuzumab, because an update has been also presented here at this ASH meeting?
Yeah, I think we saw an update of the ELOQUENT-2 trial with now 3 years follow-up that suggests that the difference in the progression-free survival curves continues to be about 28 to 30%, similar to what we'd seen before. And this time, for the first time, we saw overall survival data presented as well. And the two curves looked separate, similar to what I think we've seen from ASPIRE. Neither of those trials met the pre-specified boundary for the interim analysis, so I think we need the final analysis to really see, but certainly looked like those curves were beginning to separate.
And also, Philippe Moreau from the French group will present tomorrow in the afternoon the results of another exciting combination also based on lendex, ixazomib, the oral proteasome inhibitor, in combination with lendex, and he will see superiority also in terms of progression-free survival in comparison with the lenalidomide and dexamethasone alone. So let me ask you a provocative question. How are we going to choose the best option for our patient in first, second, or even third relapse when elo, ixazomib, and carfilzomib in combination with lendex are available?
Well, I think that it's very unlikely that there will be any trials that will guide us towards that question, so we have to use our judgment. For example, if I have a patient who needs a rapid disease control due to renal impairment or to extensive bone disease, I will favor a carfilzomib-based combination. Mm-hmm. Whereas if I have, let's say, an older lady who is concerned about frequent visits to the hospital. Her disease is progressing with anemia, but not a lot of bone lesions, not very symptomatic. I may consider an ixazomib, lenalidomide, dexamethasone regimen.
Yeah, I think that's a good way to think about it. It's not going to be if this, then that. I don't think we're at the lung cancer stage yet in terms of defining therapies. I suspect things like disease characteristics and rapidity of response are going to be important differentiators. I actually think ixazomib might be used better from a convenience perspective in the induction therapy setting and perhaps in the maintenance therapy setting as well. So I think while we have nice data in relapse, I'm not sure that's exactly where it's going to fit 100%.
Yes.
Torben, do you agree?
I agree, yeah. I think maintenance will be a major role for ixazomib.
Okay, so now let's move on to evaluate the immunotherapy. And so the monoclonal antibodies have arrived to the treatment of multiple myeloma, and daratumumab anti-CD38 monoclonal antibody is the most widely developed. And in fact, many abstracts are going to be presented during this ASH meeting. In fact, the results of the Sirius trial together with the GEN502 trial were presented yesterday, showing that when more than 100 relapsed and refractory myeloma patients received the daratumumab as single agent, responded to this combination in approximately 1/3 of them with durable responses, resulting into a significant progression from a significant benefit from my point of view in terms of overall survival, more than in terms of progression-free survival, because we are treating heavily pretreated myeloma patients. But
I think what's interesting about that data, and you may know this a little bit better, but it's not just the response and the post-relapse response that looks really interesting. It's actually this data that's going to be presented at the meeting as well that speaks to the suppression of Tregs and the suppression of the myeloid dendritic suppressor cells as well, suggesting there may be this immune focusing or immune modulatory effect of anti-CD38. Whether it's a consequence of response or the treatment, I don't know, but it's really interesting to think about.
Yeah, I think that it is a new mechanism of action for daratumumab more than the typical monoclonal antibody, and in fact I think that this should be considered as a monoclonal antibody belonging to the immuno-oncotherapeutics.
I agree.
And so I think that exciting data will be presented in combinations, and I think that Dr. Plesner will present data about the combination of daratumumab with lenalidomide and dexamethasone.
Yeah, we now have data from Phase II trial combining daratumumab with lenalidomide and dexamethasone. And what we have seen confirms what we saw in the Phase I part of it, that it's safe to combine daratumumab with lenalidomide and dexamethasone. We see very impressive response rates and very high quality responses, with 25% of the patients reaching stringent CR and an overall response rate of 81%. And what's also very important is that the responses are very durable. So we have long-term responses, and it comes with a very, in my opinion, very good quality of life with very few side effects. Actually, no side effects apart from the infusion-related reactions added to what we know from lenalidomide and dexamethasone.
In fact, this combination has been the rationale for the randomized trial comparing Lendex with Lendex plus daratumumab, and we don't know yet the results, but they will be coming probably in the next year. And another exciting combination, also based on daratumumab, is pomalidomide plus dexamethasone plus daratumumab, and I think that Dr. Lonial can comment something about this abstract.
Yeah, I mean, I think it's built on that same idea for your trial as well, that the IMiDs may enhance the efficacy of monoclonal antibodies. This was a relapsed refractory trial combining pomalidomide based on the label in the US, which is lenalidomide refractory, exposed to a proteasome inhibitor. And in a group, the trial enrolled over 100 patients. There are about 75 that are evaluable for the presentation, and it looks like the response rate approaches 70%. And I'll tell you, certainly in our center, the people that went on this were 17p deleted high-risk patients that had relapsed on 3-drug maintenance therapy. So, I mean, that kind of a response and durability is coming as well. It certainly speaks to the power of the immune oncology piece.
So I think that you are key expert on the management of daratumumab, and I would like to ask you by the side effects, especially by the infusion-related reaction. Any specific recommendation for the audience about this?
What we see is actually in about half the patients, we see some reactions during the first infusion, which are really trivial in nature, like nasal congestion and so on. Easily manageable by pausing the infusion for 1 hour, giving extra pre-medication, and then you can resume again with the infusion and treat the patient, dismiss the patient at the end of the day. So these are really trivial reactions, and they disappear from the second infusion and onwards.
And your group also used Singular as a potential way, and
Yeah.
we've adopted that as well, but I think you had the first data set on that.
We don't really have.
Yes,
Yeah,
yes.
Lucas, we don't really have data on that. We're trying to develop a data set to support that. But the idea is that it could prevent the bronchospasm of the infusion.
Right. We have to say that, I mean, as you mentioned, most of the reactions are trivial, but occasional patients may develop a reaction that may be less than trivial. Yeah. So
Just like any monoclonal, right?
Absolutely.
Yeah, yeah.
Absolutely. Yeah.
Any other specific recommendation for the audience in the management of daratumumab?
We know that Janssen now is developing a sub-Q formulation that will be tested in a clinical trial.
Yeah.
So I think
perhaps
that this new route of administration would optimize the use of daratumumab.
Yeah.
Yeah.
Let me ask you a question to Sagar Lonial, because the daratumumab has just been approved here in the US. In which specific patient population are you going to use daratumumab as single agent?
Well, I think right now the label in the U.S. is greater than 3 prior lines of therapy, resistant to an IMiD and a proteasome inhibitor. So I think that's where it's going to get used, and the first shipments of commercial drug have already reached the clinics, and I know several patients have been dosed already. I suspect, though, with the data combining with POM as well as other drugs, that's going to really start to happen much more frequently, because even if the IMiD, even if the tumor cells are resistant to the IMiD, it's possible the addition of the IMiD may enhance immune effector cells, making the antibody even better than it is by itself.
Actually, in the early days, I enrolled a patient in the GENMAP trial 503 who was formerly refractory to lenalidomide because he had progressive disease within 60 days after finishing lenalidomide, and he responded for almost 2 years to the combination of DARA and Dex.
So I think that these are exciting data, especially for the management of our patients with myeloma. And before finishing this discussion,
Perhaps,
I would, of course.
I have a comment about we need to educate our colleagues about using that daratumumab, and there are 2 important aspects to be aware of. One is that it's important to have a blood typing done before you start treating patients, because DARA is bound to the red blood cells and will cause trouble in the blood typing after treatment. And the other aspect to pay attention to is that DARA will circulate in the plasma of the patient, so you will see a small monoclonal band because DARA is IgG1 kappa. So you will see a small monoclonal component in the serum of patients, and that should you should be aware of that, because it can be tested and shown that it is indeed DARA, so you can confirm that the patient is in CR if you suspect.
The same applies with elotuzumab too.
Yeah.
IgG
So
kappa.
I think that a general comment for the physicians who are going to treat their patients with monoclonal antibodies is please look at the serum protein electrophoresis to look at the M component of the patient and the M component corresponding to the monoclonal antibody to well evaluate the response.
Yeah, especially when you are reaching a VGPR state, and you see that there is a very small residual.
It will typically be an M component of 0.5 gram per liter.
And less.
It's very interesting.
That level.
Our lab is so used to seeing it now that they're calling it. They're seeing the band on the SPEP and saying this is daratumumab.
Directly they are able to allocate daratumumab. Daratumumab is allocated at the end of the gamma region. Elotuzumab is allocated at the beginning of the gamma region. So different monoclonal antibodies
Well,
are
I
allocated
mean, to
in
prove it,
different
you need
places.
special immunofixation, of
You do,
course.
you do, but they can
Absolutely.
see where
Yeah.
the old band was, so they
Yeah,
know
yeah,
it's
yeah,
not
sure.
where the old band was.
Okay, last question. Where do you envision daratumumab in 5 or 10 years' time?
Well, I think that daratumumab is very likely to become a backbone for the treatment of myeloma, and for sure, quadruple combinations will be used in the frontline setting, especially for younger patients who may move to high-dose therapy, and then as consolidation. And it is logical that, especially with the synergy that we see with lenalidomide, it will be used as maintenance therapy for at least several months.
I'm glad as the European you said that, because that's exactly what I think as well. It'll be a 4-drug induction regimen, and I think one of the trade-offs, if we do 4 drugs up front, is that you don't have indefinite maintenance after transplant, that you might be able to get low enough that you
Right.
can stop therapy
And
at some
hopefully
point.
with the MRD data and the trials that will
We will
have
be
to
able
be
to
performed.
stratify the therapy
Yeah,
according to
of
the
course.
MRD status to individualize much more the treatment of our
Of course, we need
patients.
these studies to be done first.
Yeah.
The
Torben?
nice thing with daratumumab is there's no overlapping toxicity to any of the other drugs we're using to treat myeloma, and it has a separate mode of action, so this comes in as a very important feature. So I think that Dara will be the rituximab for myeloma in the future.
Any additional comments, Sagar? Or
No,
not?
I agree. I agree.
Thank you very much for the discussion, and we close here this roundtable discussion from Orlando in Florida about the highlights of myeloma from ASH 2015.